Good afternoon, everyone, and welcome to the Nutrition Policies to Promote Healthy Aging and Health Equity, sponsored by the National Organization of Black Elected Legislative Women. We call ourselves NOBEL Women, and Defeat Malnutrition Today. Listen, I am Georgia State Representative Kim Schofield, and I welcome you today for an afternoon full of information, exchange, knowledge, and an overall great conversation with two of the most amazing speakers that one could ever encounter. I introduce to you Dr. Patricia Lynch, who is a professor and director of the didactic program in dietetics at Virginia State University. She collectively has an extensive background in research, educational and environmental, focusing on nutrition, outreach, serving underrepresented and underserved populations. She has such an amazing background that if I told you everything that she has done and continue to do, it would make your head explode. And she's going to tell you more about her amazing work throughout the conversation. And Robert Blancato, we call him Bob. Bob is an amazing executive director of the National Association of Nutrition and Aging Services. Bob, listen, I told Bob I would just say he is fantastic. He has done work with AARP, and he has served in various capacities in policy. Oh, he's got over 17 years of experience. To know Bob is to know that he comes with a wealth of knowledge that he's going to share. So without delay, I'm going to turn it over to these amazing speakers. Get your pen and paper. They are going to give you notes. You're going to be able to take these policy changes and impact your constituents, your community, and really make a lasting impression that will shape the nation. I'll turn it over to you and we'll get started. Laura, take it away. Pat, it's on you.
Okay. Well, I'm going to follow this agenda. Again, I say welcome all of you guys, and it's a pleasure coming here. Let's go with slide one. I'm an associate professor at Virginia State University, and I coordinate the didactic program in dietetics, dealing with nutrition programs. Next. Now, who is Virginia State University? What do we do? Virginia State University is a small institution. It is about 130 miles south of Washington, D.C., and about 135 miles or so north of Raleigh, North Carolina. So I want to talk a little bit about the university and a little bit about the dietetics programs and how we can fit into this change that we're trying to make with malnutrition. So who is Virginia State and what's in the name? Well, Virginia State University was founded in 1882. It was first established as the Virginia Normal and Collegiate Institute. However, during that time, civil rights was strong and a lot of things were going on. So it took them a few years to actually put the collegiate part back into the college. So sometime in 1930, actually, Virginia State actually became Virginia State College for Negroes. And in the meantime, the land grant program was moved from what we call today Hampton Institute, which still is a private institution, and moved to Virginia Normal at that time Institute. So now in 1930 it became the college, which took an act of Congress, if I should say so. And then in 1946, it actually became Virginia State College. And then later in 1979, the legislature provided the current authorization for it to be the Virginia State University. Next. So the university has 36 undergraduate degree programs, 18 master's programs, 2 doctoral degrees program, and 8 certificates. And one of those certificates is the didactic program in dietetics, and also a certificate in the internship program. Virginia State has about 4,800 students. The campus itself is 231 acres, and there is a farm of 412 to 416 acres. Next. So one of the challenges with what we're doing is that we're challenged when we think about the aging population with nutrition, just being healthy. So by 2040, we realized from research and statistics that about 81 million Americans will be 65 years older. And which in 2040, that'll be 21% of the population. Right now, we're looking at 16%. And the states that have the highest percentage of older adults are Maine, Florida, West Virginia, Vermont. And healthy aging starts with good nutrition. With the number of individuals that will be 65 and older is continuing to rise. So there is an urgency to secure some type of future healthy aging, and we want to start with nutrition. So the nation's role in healthy aging. So what we want to do is maintain functionality in the aging population. So we know that individuals that are older, they make significant contributions to the social environment. But it depends on their health, and it also depends on whether they're aging healthily and they're eating well and they're in good healthy condition. So good nutrition supports healthy aging, which supports independence. Malnutrition, on the other hand, leads to poor outcomes, which leads to frailty and disability. And when we think of frailty and disability, we think of the amount of expenses it take for us to continue to support the aging population when they're not, when they are malnourished. Now, we know there are difficulties with eating, poor diet, and other nutrition issues, including malnutrition. Right now, a lot of them remain unidentified when people go to the hospitals or when they're seeking care. So, but malnutrition is a significant contributor to frailty and functional impairment, and most of all, the poorest quality of life. Next. So older adults, malnutrition is a growing issue. Malnutrition is considered, as we know, a state of deficit, not just of calories, or we're also talking about nutrients. State of deficit, mostly, and many times it'll be protein and energy and other nutrients that we may not know about. And what happens, it affects the individual's body as well as the clinical outcomes. For many older adults, the lack of adequate protein and loss of lean body mass are particularly significant problems. And that includes people that are overweight or obese. The importance of malnutrition prevention for older adults is magnified as it affects their independent living, it affects healthy aging, it affects the severity of the conditions and disabilities that they may incur. So the nation has been referred to as nutrition has been referred to as a vital sign of older adult health. Good nutrition has been shown to help support a healthy and active lifestyle. It improves their health outcomes. It reduces healthcare costs, in stark contrast to malnutrition, which, particularly individuals lack protein, they lack calories and other nutrients that's needed to repair and maintain, tissue health. So malnutrition in older adults is a significant public health concern. with increasing prevalence. So it's estimated up to 50% of adults who are admitted to hospitals, they are either malnourished or at risk for being malnourished. It has a negative impact, not just on their physical and mental status, but as we mentioned earlier, it increases healthcare costs and it increases their hospital stays. So despite the efforts to improve this type of care, we're still seeing undertreated care, and obviously a lot of it is because we don't recognize it's not being seen or analyzed, when people go to the hospital or seek care. So up to 1 out of 2 out of 2 older adults is either at risk or they are malnourished. $51 billion is associated with disease associated malnutrition in older individuals. So, and protein calorie malnutrition is related to hospital stays. They're twice as longer than the average person without malnutrition. Next. So deaths from malnutrition have more than doubled in the past 2 years. So there was a study with the Kaiser Family Foundation, and we were looking at the percentage of individuals that are dying in the past 2 years. We're looking at the years between 2020 and 2022. So in 2018, it was approximately 650 individuals, per 10,000 that died. So right now, or in 2022, there's roughly 1,400 per 10,000. So that's a significant part of our social community. So in many of these individuals that are dying, they may be in their 80s, but their deaths are related to nutrition or poor nutrition or malnutrition. So we're looking at and trying to investigate. I mean, there are a lot of reasons that people have died over the past few years, and COVID is one of those. But when we get information that these individuals are dying because of malnutrition, then we have a different type of job. No person in the U.S. in this time of history should be dying from malnutrition. Next. So malnutrition in older adults is a health equity issue. So social determinants of health contribute to risk factors for food insecurity and malnutrition. So it is linked to food insecurity. Substantial disparities in malnutrition diagnosis and readmission exist. We don't see a lot of the malnourished individuals, or it's not documented as being malnourished. And then, as we mentioned earlier, upon readmission, the stays are longer. They come back more often. So with effective screening, assessment, diagnosis, and intervention, malnutrition can be identified and then ultimately addressed. But we have to be in a place where we identify it first. Next. So let's talk a little bit about nutrition-related policies. And one of the largest one that's going on right now is the White House Conference on Hunger, Nutrition, and Health. So the first White House Conference on Nutrition was about 1969, and that led to the development of WIC and then the Older American Act's nutrition programs. And that was in response to, the social environment and the lack of social services for older individuals. So the original legislation looked at establishing some type of authority for grants to states for community planning and for social services, for research and development projects, and for personnel training. And all of these would be looking at aging individuals. So right now, older individuals may receive services under many other federal programs, that may be related to vehicles such as nutrition and social services. So the White House conference that just recently held in 2022, they were established to provide a roadmap to end hunger and improve nutrition. And it's quite ambitious, but we're up for the task. We're looking at by 2030, we want universal screening for food insecurity in all federal health programs, and then increase funding to the Older Americans Act nutrition programs. So federal agencies are taking action right now with more challenging rollouts coming regularly. Next. So the USDA assistance, nutrition assistance programs include the supplemental nutrition program, that's what we call SNAP. Now, those programs that program is also available for older adults, but it has quite a few barriers. And some of those barriers include the application is burdensome for older individuals. Some of them don't know whether or not they're eligible, or there is some shame associated with having to, get this type of funding. So the Senior Hunger Prevention Act of 2023, introduced by Senators Casey and Gillibrand and Fetterman, the objective of that legislation is to make it easier for older adults to enroll federally. So now the objective is that states can make similar changes to streamline state enrollment and provide education about SNAP, because we're finding that a lot of older adults don't know about SNAP. And when they have a conversation about it, they're thinking that it's for younger people and they may not be eligible for it. And at the same time, they are. So, and there's also a senior farmers market and child and adult care food program, which also support nutrition for older adults. The senior farmers market provides access to fresh produce, and the child and adult care food program provides meals at adult daycare facilities. And the commodity supplemental food program also supplements diets to low-income older adults. Next. So what can we do to make some of this work for us? So we're looking at streamlining SNAP applications and support flexibilities in those examples. For example, during the pandemic, SNAP flexibility involved, waivers of face-to-face interviews at both the initial application and then again at recertification. So why are we not doing that? We need to pull people out of a malnourished environment. So what can we do to make it easier? So this would be a consideration. There is disaster SNAP streamline process, and this benefits are delivered within 7 days of applying, and then the individual will be issued 1 month of benefit while they're waiting for the application to be reviewed. Injunctive eligibility. When we look at WIC applicants, their income eligibility is associated with whether or not they receive Medicaid benefits, and they use that as an online type of confirmation system. So Medicaid for older adults could use a similar type system. Older adults, simplifying the application process. So simplified to 2-page application. It waives recertification, interview. It also extends certification period to 36 months. It would include data match for identity, medical expenses like Medicare, and income to determine eligibility. Next. So other policies to support malnutrition care and health equity. Nutrition education of health professionals. And this would include nutrition education in medical schools and interprofessional education training programs. Right now, very few nutrition courses are offered in medical schools. Their focus is on other types of courses. So we are advocating more nutrition. I think the more of us that understand nutrition, the more malnourished individuals would not exist, So nutrition research. So right now we see a lot of nutrition research, but they don't include older adults necessarily, and even less of people of color that are older adults in the research. Medical Nutrition Therapy Act, we could expand Medicare to cover the MNT to chronic diseases other than right now, they're only covering renal disease and diabetes. I mean, there are a bunch of other diseases, that we could be covering with this Medical Nutrition Therapy Act. And we know, and it's been proven, that individuals that get nutrition care from, chronic diseases obviously help make significant behavior changes toward the betterment of their health. So the 2025 and 2030 dietary guidelines for Americans, we could include nutrition recommendations for older adults. And it had been recommended in 2019, but it was not taken into consideration at this point. Next. Okay, dietetics and nutrition workforce, size and diversity. So the big question here, we're still talking about nutrition and malnutrition. So who delivers nutrition care, and do those individuals reflect the experiences and the culture of the populations that they serve? So, and the other question is, nutrition and dietetic programs, they need specific funding. Next. So when we look at the poverty among Americans that are 65 years old and older, the largest percentage of the poverty rests within the minority groups. As you can see, those individuals of color. Blacks is about 18%, Hispanics next 17%, and then we have 9% Asians, and whites are 6.8% next. So keep this little table in your mind. So now when you see the demographics of the dietitians in the US and relate that to the percentage of individuals requiring care, you see only 3% of those dietitians are Black. Only 5% of those dietitians are Asian, and only 6% of those dietitians are Latino or Hispanic. And we're talking about 80% of the care is being delivered to people of color by individuals that are white. Not that that's a concern, but we know from research that the more a patient receives care, direct care from an individual that understands their language, understand their cultural barriers, understand the experiences that they've gone through, they are more receptive to care and obviously changes not just in behavior, but in their health care. Next. So the other side of getting professionals to handle nutrition or malnutrition, race and ethnicity of dietetic students becomes an issue. So here we see the number of, or the percentage of people of color in the colleges and universities that are trying to become dietitians. So here we show 7% of those students, we're talking about an internship and dietetic programs, are African American. And less than 25%, a quarter of all the dietetic students are dietetic students of color, including, Hispanic, Latino, Asian, and Black and African American. So if we are going to get to the professional, increasing the number of dietitians that we have to serve those individuals of color, then we have to find a way to also increase the number of students, not just to come into the dietetic program, but to leave that program, and go into the profession. Next. So this is a picture of one of my classes. This was a 2017 class, but I want you to to see what my class looks like. I'm so grateful that, I have a loving bunch of people that I've worked with, and they all are in the dietetics program. So this is an example of how care works. Now we can see the number of minority students, but that's only a small part of the picture. Now, most of these students here, they are in a dietetics program to become dietitians, but this student will become or is in a medical in medical school right now. And this young lady chose another field of study. Once she finished, she already had a job, so she stayed with her job. And this young lady is a parent. She enjoys taking care of young children, so she's continued to take care of young children. And this young man went into the military, so he's in the military, but not a dietitian at this point. And this young lady, she became a dietitian in the community. And these two young ladies were dietitians in hospital care. Next. And this next picture, these are pictures of students that I work with, and they are looking at becoming dietitians as well. And we know this person is going to be a medical doctor, physician. But so when we talk about getting more students into the field, we have to start with a larger group of students. My program may graduate 10 students a year. So in that program, not 10% the 10 students that graduate will not all become dietitians. So not only is that an issue now, because some of these students they're going to have to get out and go to work regardless of what they chose as their major field of study. So we're looking at other ways to not just attract students, but to retain them and help them get to that path. And I think some of that pathway is in our profession, students have to do an internship that is not paid, is usually between maybe 10 and 18 months, depends on the institution. And it is not paid. So if you have family, like many of my students do, these are people that have families and children and husbands and wives. So, and they can't move for many of them, and others, you can go to school for a certain period of time, but then after that, the internship becomes a little problematic. So in just last year, this year in 2024, we will begin a program where we can only have a master's degree program that students that will be sitting for the exam. So we are looking to see how that's going to impact the profession, not just the students, but the profession in the end. Next. Okay, Virginia State is a land grant institution. So these are some of the things that we're looking at in terms of what can we do in terms of malnutrition or in the community or helping with aging. So enhance the infrastructure, facilities, and resources that are necessary for conducting research and providing quality education in the field of malnutrition. Attract talented individuals to land grant HBCUs and encourage them to contribute to research, practice, and policy development in nutrition and dietetics. Incentivize partnerships between land-grant HBCUs and other institutions such as medical centers, public health agencies, cooperatives, grocers, and community organizations. Develop a comprehensive and interdisciplinary curricula that focus on malnutrition care. And then lastly, provide opportunities for faculty and students to participate in legislative hearing, advisory boards, and task forces to ensure that their expertise is considered in the development of policies that are related to malnutrition care. Next. I think that's my last slide. Thank you very much.
Dr. Lynch, Representative Schofield, thank you for that presentation. And it was amazing, some of your research and your studies, and really what bubbled up and really made it personal for me, and some of your work, especially in malnutrition care. It hit me that one of the major issues that I'm dealing with now with my mother, who is 85 years old, who lives by herself, is the fact that there's a stigma that is associated with malnutrition. And she says to me, I'm losing weight.
Mm-hmm.
But there is such a stigma about talking about malnutrition. Can you share with some of us that are on this call right now, how do we have that real conversation with our parents about malnutrition? We know that, again, it's a workforce, and this plan that you laid out is really the next stage of how we have to start dealing with malnutrition care. But in our culture and in our communities, how do we have the difficult conversation?
And I agree with you totally. The older individuals, I mean, these are individuals that we have looked to all of our lives for good nutrition, cooking for us and taking care of us. And now they're at a place where when they start feeling unwell, or if they're losing weight, they may not always tell their children or their neighbors that they are losing weight, because like you said, it is a negative stigma. And for many, they know that poor nutrition leads to other types of care that will take them out of their homes and will put them places where they don't feel like they will, be able to see their family members, and we were talking about long-term care and assisted living, different places where these are independent individuals that live in their homes, and they built a home, they raised their families, and they don't want to be seen as someone that can't take care of themselves. And for us, we need to be more proactive because, at one point they took care of us. Now it's our job. And in the United States, we seem to care less for the aging population than in other cultures. And I feel that some of the money that we're spending, we could spend more, only because we don't respect aging as other countries. And I've traveled a little bit, and other countries bring out their older individuals. They want you to meet somebody that's 100 years old. So I think one of the things we can do is make sure that not just visiting, but pay particular care to their weight, their skin, their conversation, have meals with them regularly to see how they eat. Are they having problems with intake? Do they have problems with teeth, with chewing or swallowing? And all those things are important, because those become issues that they're not going to tell you that their mouth is not right, or they're having problems swallowing. You have to see that. And if nobody ever sees it, they continue to lose weight. And the other issue is many of our elderly they're living alone. And when you're living by yourself, especially when you lose track of time, you don't always know when it's time to eat. I grew up in the farm. We had a little bell that rang every day at midday to let us know 12 o'clock, it's time to eat lunch, So you get up, you eat breakfast, and you have a little bell at lunch, and then you have something else at dinner. But for these individuals, they may not have that cue because they're older, letting them know that I'm hungry now, or it's time to eat, or whatever. And if they're alone, there's nobody to eat with. It may not be an enjoyable social event anymore, like it was when the tables were filled with all the kids chattering about what their day was about. So it's different. It's on us now, whether you are a child or sibling, or whether you are a neighbor or just someone that comes to visit. We need to pay more care. And there needs to be intervention where, if they need care, we have places that we can bring care to the home rather than taking them outside of their living quarters, so.
Thank you, Bob. I'm going to shoot it over to you.
Thank you very much, Representative Schofield. It is a pleasure to participate and co-host this event with NOBEL Women. I've had the pleasure of communicating with NOBEL Women before at conferences. It's good to see this today. Dr. Lynch, thank you for a brilliant presentation. It covered many things. And before I go to my slide, I want to mention two things. Number one, that we're holding this webinar on a very opportune day. Today's the first day of Malnutrition Awareness Week in America. It was created by our friends at Aspen, and it is soon to be recognized by a bipartisan resolution in both the House and the Senate. The House resolution sponsored by Congresswoman Bonamici from Oregon and co-sponsored by Congressman Bacon and Congressman Fitzpatrick. And in the Senate, we expect Senator Murphy of Connecticut to author the same resolution. And it's a very important recognition of an important week that we need to focus more attention. And we're glad to contribute to Malnutrition Awareness Week with this webinar today. So next slide. So who are we, our Defeat Malnutrition Today Coalition? We are a proud group of over 120 national, state, and local stakeholders and organizations, covering the gamut of people who care about nutrition, who care about older adults, who care about advocacy, and who care about healthcare. And, you know, because we are who we are, our focus as a Washington-based coalition is to create policy changes toward a greater emphasis on screening for, detecting, treating, and preventing malnutrition. By doing so, we do it through the legislative process in the Congress, the regulatory process with the administration here in Washington, but also through state policies. And we work very closely with a number of states to get resolutions adopted around either Malnutrition Awareness Week or creating commissions to look into malnutrition for their state. Next slide. And probably our proudest moment so far in our years of our coalition was when the Centers for Medicare and Medicaid Services adopted the first ever global malnutrition composite score quality measure in their inpatient hospital rule. And it's the first nutrition-focused quality measure ever adopted by CMS. It's a measure that will improve patient health outcomes because it advances CMS's own equity plan for improving quality care in Medicare. It also helps to meet the Joint Commission requirements and non-for-profit hospital community health requirements. And it's a recommended rural health measure. And as you can see, it has the 4 components of screening, assessment, documentation, and then a nutrition care plan. That makes up this very important and historic quality measure. Next slide. We also want to focus on state hospital quality of care regulations. Because, you know, as we know, not everything happens in Washington. People in Washington think everything happens in Washington, but that's not the truth. We know that the states and localities have a lot to say about quality of care. And state regulations shape the quality of care that patients receive, including in the nutrition space. Yet, sadly, state hospital regulations rarely include nutrition and even less so malnutrition. The states that are starred on this map, Colorado and Nevada, could be templates for including malnutrition in state quality of care hospital regulations. Next slide. So using Nevada as an example with their state law, it has some very clear language about a hospital should carry out a program for the systematic nutritional risk screening of its patients to detect annual and potential malnutrition at an early stage. And we all know the importance of detecting at the early stage. If it's determined that the nutritional status of a patient is at risk, nutritional care for that patient must be planned and provided based on the assessment of his or her nutritional status by a licensed dietitian or the attending physician or both. And then, of course, integrated into his or her plan of care. And then the response of the patient to that plan must be monitored and reassessed as needed. And then, of course, pertinent dietary information must be included in a patient's transfer records or discharge records or both to ensure continuity of nutritional care. Because there isn't a hospital in any state that I know of that wants to have increased readmissions caused by something that could be prevented with good quality community-based nutrition care. Next slide. So the Older Americans Act is one of the more important, if not the most important, nutrition program for older adults and has been for over 50 years. It has 3 purposes, okay? To reduce hunger, food insecurity, and most recently in the 2020 amendments to the Act, added malnutrition to that list. This next point just came up, actually, Dr. Lynch, you brought it up very well, and Representative Schofield as well. The connection between nutrition and socialization should never be understated. One of the real tragedies of the pandemic was the fact that before the pandemic, 2/3 of older adults in the Older Americans Act nutrition programs got their meals in congregate settings, sitting with other people, friends, neighbors, and so on. And in a separate work that we did with our National Association of Nutrition and Aging Service Programs, we canvassed many of those older adults in nutrition programs, over 500 of them, and asked them what was their main reason for coming to the program. And the answer was socialization. And so this is a key element of the act, especially now with the increase of isolation and loneliness as a outgrowth, if you will, of the pandemic. And the third purpose is to promote health and well-being, an obvious one. But it's been obvious, this was written years ago, but it's taken a long time for us as a nation to recognize the connection between nutrition and good health. The Older Americans Act programs include Native American specific programs. They are not fully funded by the federal government. They rely on state and local funding, charitable donations, and of course, contributions from Older Americans Act participants themselves. And as recently as a few weeks back, when we did a study from our NANAS group, we're finding that 1 in 3 older adults may be on waiting list right now as we wait for the aftermath of the pandemic to continue. Next slide. And we want to talk about 2 things that are going on right now. One is on the federal side, the Administration on Community Living is requiring state Older Americans Act programs to develop multi-year plans to foster healthy aging. But we have done a little bit of work in this space and reviewed state Older Americans Act plans, and only 1/3 of those state plans mentioned malnutrition, and even less, 8%, had malnutrition prevention as a goal. And so clearly that needs to be improved. And there's a provision in the Older Americans Act law that calls for states to have malnutrition prevention plans in their state plans, but it needs to be enforced. And I think with an upcoming Older Americans Act renewal next year, that'll be a topic to look at some length. And then on the other side, going back to the states for the moment, we are now seeing the development of what they call multi-sector or master plans on aging to provide blueprints to guide and structure state and local policies and programs toward promoting aging well in local communities. Now, almost half the states in this country, in fact, most recently, North Carolina and their governor just signed an executive order for a master plan on aging and a multi-sector plan. So we have a lot of states moving in that direction, but we're not seeing enough, in our judgment, of references to nutrition. And one of our targets will be to address that. And there's also, in addition to this activity at the states level, there's now an interagency coordinating group that was established by the Department of Health and Human Services, where they've named the Administration for Community Living to operate it, to focus on healthy aging by checking into all the federal agencies have programs in that area. And we know that coordination is very important in getting the full value out of resources that you have. Next slide, I'm sorry. So we're going to talk about an example in the state of Ohio, which, by the way, I'm not sure, I think these things are connected, but they had a malnutrition commission in their state, a high-level commission that produced a number of recommendations, and I'm sure the outcome included this state plan to advance the goal and achieve the objectives above of healthy living. The state will implement and invest in the following evidence-based informed strategies, okay? In the area of improving nutrition, every one of these is important, but important because they connect to each other and need to connect to each other, okay? SNAP enrollment ties to community-based healthy food access. That is a critical element of access, is to get people enrolled in SNAP. And we know for a fact that less than 50% of older adults are enrolled in the SNAP program, even with great efforts being made by groups like the ARP Foundation and the National Council on Aging to enroll older adults. But we have to do better in that space. We need retail-based supports and incentives and healthy eating incentives, as they call for in Ohio. The workforce shortages. We must address the workforce shortage everywhere in the nutrition and healthcare space. Disease management and malnutrition prevention and treatments. These are all under the category of the outcome of improving nutrition. And then in the malnutrition prevention and treatments, some interesting ideas about community gardens and mobile produce markets and the supplemental food programs, and having a variety of choices on how nutrition can be provided to older adults, including Kyron Good Grab and Go and home delivered meals. Something that's very important, and I think goes to the conversation that Dr. Lynch and Representative Schofield had about expanding nutrition education. We need to continue to educate people about the difference between good food and bad food, and the importance of good nutrients to preventing malnutrition. And of course, increasing screening, assessment, diagnosis, nutrition counseling, medical nutrition therapy, improving discharge planning for malnourished patients, such as being able to send them to Meals on Wheels programs when they get discharged. So these are some really good examples of one state that's taken a lead in this area, and we hope more will do so. Now, next slide, moving to the master plan and multi-sector plan on aging. California is leading the nation in that area. They have completed their work and are in the full stage of implementation for their master plan. And they're going to pursue affordable aging through 3 strategies: protection from poverty and hunger, and have, during both last year and the year before, having a series of public health education tools with culturally competent and equity targeted approaches that address healthy aging priorities such as nutrition, and map and identify opportunities at the federal, state, and local level to address older California's needs for nutrition. These could be, and there will be, efforts made to broaden it to include malnutrition. As an example, to improve nutrition through malnutrition screening and treatment of malnutrition or malnutrition prevention. Next slide. So since I feel like I'm an advocate, and I'm happy to be an advocate, it's always about what can you do, okay? And it's all about voices speaking up for any particular issue that you care about. And today's issue, it's about quality malnutrition care and health equity. And the more voices that speak up to connect these two and push for this, the more likely these issues can be and will be addressed. So we ask for you to advocate for nutrition and related policies, including quality malnutrition care supporting older adults at the state and the federal level. We want you to advocate for promotion and funding of HBCU dietetic and nutrition programs and 1890 land-grant institution food and nutrition programs. Dr. Lynch's chart earlier should tell you exactly why we're pushing and urging the advocacy for that, to improve and increase the number of persons of color who are dietitians in this country. And then we're also asking you to advocate for including malnutrition policies in state, Older Americans Act multi-year aging plans, and state master plans on aging, and to educate older adults about SNAP benefits so they understand there's a benefit to enrolling in SNAP, let them understand their eligibility and help streamline their enrollment. If we can do all these things, then I think we can say we are making an important contribution to improving the quality of nutrition care and health care for older adults. And my last slide I'll leave up is a resource slide that can connect you to some of the things that we were talking about today. And with that, I will turn the program back to Representative Schofield.
Thank you, Bob. I mean, this has been amazing. I told you guys y'all were getting a wealth of knowledge. And when we talk about the reasons why we have to be the voice, these are the people that sometimes don't know how to speak up for themselves. And so now I'm going to open it up to some questions. And our first question really is, can you, either of you, explain your effort to increase the number of Black dietitians?
Well, I guess I'll go first, Bob. Well, one of the things that I am doing, I'm part of a policy committee with the Academy of Nutrition and Dietetics. So we're looking at not just funding, but mentoring and some other things to increase the number of students of color. And in terms of the university, we are recruiting. You know, we go out of our way to make sure we are in environments where students of color may be. And we also are looking at, in terms of my program, personally, we look at ensuring that the students that come in, they're going to leave, they're going to be retained, and they're going to go into a program, which means that they need to go into an internship after they leave me, and they need to take a national exam, which they need to pass, and then they become dietitians in hopefully communities where they're needed.
I think from our side, in our coalition, we're very proud of the fact that we have strong groups like NOBEL Women, the National Center and Caucus on Black Aged, the National Black Nurses Association, longtime members of our coalition who can help us in that very specific advocacy point that I made earlier about promoting and funding of HBCU dietetic and nutrition programs. And any other federal program that's out there that provides aid for people in colleges and universities that can help them achieve their goal, we will support that as well. So we'll be doing it on the advocacy front as other activities go on in the country.
And I wanted to add too, the USDA has funding for our scholars. I mean, they have an 1890 USDA scholarship, for as much as $10,000. So students, that are interested, there are ways that we can get them places, so we just have to be aware.
Right. And I also, let me throw one more thing. I think the Centers for Medicare and Medicaid Services equity agenda needs to have a clear delineation on pushing that particular point forward, because we got to be thinking about the future. We got to be thinking about who's coming up in the ranks. And this is a great place to start.
Absolutely. Thank you. Thank you. The next question comes from Representative McDaniel, and she says her mom says she's not hungry. However, she notices that she eats when someone eats with her. Do you have any advice to help her get an appetite, or what can she give her to increase her appetite? It's almost like the same thing with my mother. When I asked her, so what'd you eat today? She said, oh, I just had a salad with iceberg lettuce. And she's always been a picky eater. She lives by herself, but how do you get them to increase their appetite when they're either by themselves, or like Representative McDaniel says, she only eats when somebody eats with her. And my mother lives in New Jersey. I'm in Georgia, so I don't know if they live near each other, but it's a challenge.
Well, that is a challenge, and it's part of what I was mentioning earlier about the value of socialization in any nutrition program involving older adults. I think one of the things that we shouldn't overlook is the power of technology in this situation. Having virtual lunch companions can be one approach that could be looked at. There are a lot of technology programs out there now that are providing tablets to older adults that can allow them to connect to a friend. And when it gets to be lunchtime, they could do this. They could have their meal together and in effect be together. And I think it's important that everybody understand who's in their aging network, their local aging network, that can provide some guidance and some help on that very point about companionship for people when they're living alone and don't want to come out. But there are, but of course, at the same time, it's important to recruit whoever is able to go to a congregate site to have their meal. Okay, because there's more than a meal at these sites. Okay, there's oftentimes a lot of other activities that could also promote healthy aging. I mean, this is National Senior Center Month, by the way, too. And if you look at today's senior center, there's a bevy of activities that are going on. You could make a 3 or 4 hour commitment and come out of there with all kinds of improvements to your mental and physical health. Eating being the centerpiece, but everything else around it. So it's a combination of having resources and knowing where they are, and maybe tapping into some technology opportunities.
And I agree with everything Bob has said. We have community events, for example. Many of these women and men, they're part of church programs, faith-based institutions. And a lot of those folks get together at least once or twice a week just to have a meal. They get together and eat meals on Sundays or different days, but there are many outlets. If we see that they're eating because someone is available, someone's with them, that's one thing. But the other side of that sometimes we dietitians look at is, what are those medical issues that may be concerning that they may not tell you? Are the medications taken away their appetites, or that it's too much medication for the amount of food that they're eating. So do they need an appetite stimulant? But if they're happy because people are there, that's a measure right there that we need to be increasing their opportunities to be with other people. And one of the things that we will be doing, we are doing a little of it, but we will be doing more, is have our interns and our students do these things, as Bob just talked about, have them present to have conversations and, entice them into talking about things that they may have forgotten about, things that they like to talk about. So as he said, they'll walk away feeling like that was a wonderful, not just a wonderful meal, but that was a wonderful social activity,
Absolutely. Another question, what policies can be implemented to incentivize healthcare providers and caregivers to screen for and address malnutrition in older adults during routine health visits?
Let me start on that one. If one program that does exist but needs considerably more funding is the National Family Caregiver Support Program of the Older Americans Act. Mm-hmm. It is the only program of its kind that helps to prepare and train individuals to become family caregivers. And that would include things like screening and assessing the condition of the individual that you're caring for. Unfortunately, as many people in this country know, a lot of times caregiving gets thrust on you suddenly, and you don't have enough training. And I was very proud, as I told Dr. Lynch, I'm on the board of AARP. I used to be the state president in Virginia, and Virginia was the third state in the country to pass the CARE Act, which is a piece of legislation now in over 35 states that trains a family caregiver to understand all the tools that they need when the individual is discharged from the hospital and they become the caregiver. How do you make sure it works? How do you know the right things to do? And now there's a statute that calls for hospitals and caregivers to work together on that very point. And on healthcare providers and on the screening side, I think, it should be mandated. If you're getting federal funding, there should be a provision in there that calls for you to do screening as part of your work. Because again, it's in your ultimate best interest if you're avoiding people getting readmitted to hospitals, so you can assess. So those are my thoughts.
And I just have one to add, and I agree with you, Bob, as well. Those are excellent opportunities. For me personally, the Medical Nutrition Therapy Act, it needs to be expanded. I mean, we're only providing opportunities to meet with a dietitian when a person has diabetes or renal disease. I mean, imagine all the things that people can, even obesity, hypertension, dyslipidemia, HIV infections. I mean, there's a lot of other things that we need to send people to dietitians for nutrition care for, and we just hit the tip of the iceberg that's out there. So
I have a suggestion that came from Teresa Scallard. She says, suggests for the challenges with aging relations, having a self-screening, MNA elderly, and contact their doctor, send to a registered dietitian and get MNT coverage. All right, so that was one. And then this was from Kelly Bond, not a question, but currently in Northern Kentucky area, we're introducing an electronic platform called ShareBright that will allow multiple senior centers to communicate with one another, share a meal, etc. It's almost what Bob said. Also, a tablet will provide to allow senior adults to communicate and become involved with the meal activities while at home. Great suggestion. Listen, I see that Elva Gray Jackson has her hand raised. Can we let her in to ask her question? Can we unmute her? Laura? I'm not sure I can do that, but Elva, if you can type your question, I don't know. Oh, she must have left. Okay. Well, we will move on. Any other questions that come in? If not, here's another question. Now, there are opportunities to establish guidelines or regulations to improve the quality of food and nutrition in long care facilities, such as nursing homes, to better address the nutritional needs of aging residents.
The answer is yes, that is part of a comprehensive Biden administration efforts to improve the quality of care in nursing homes across the board, including nutrition, quality of food, and staffing, and infection control, and all these other things. The pandemic, as everybody knows, exposed many of the shortcomings of today's nursing home environment. And the issue about nutrition has always lurked in the background. But now that there's such a spotlight on nursing home care, it's finally getting brought into that conversation as these efforts at reform continue. But you got to remember, it's very important that having good food in a nursing home is important, but having qualified staff to help individuals understand the importance of nutrition is also critical. And that's part of what the president is trying to do.
Absolutely.
So you have, Brett, gave some good tips, and I will challenge my Nobel women and all those that are in places of influence that one day we will be older. And we will be in this position. So now, while we have an opportunity to change the landscape and ecosystem, let's do better. You've given some great comprehensive tools, a toolkit. One of the things that I wrote down is that we should automatically be doing a malnutrition awareness resolution in every state. That's just a no-brainer. So that's something we should do. We should also be looking at malnutrition prevention plans. I know Bob and Dr. Lynch gave us some great tools that we can do. But going forth, let's look at how do we start a malnutrition commission or work group on malnutrition care. We've got states like Ohio and California that are doing good. So we have the ability, ladies, to do more. And I think we should take advantage of this wealth of knowledge that has come before us to do better. Representative McDaniel has a question. Do we have data that may be able to show how Medicaid expansion for states like mine can assist in providing funding for this matter in older Americans? Where's the data?
I'm sure it exists. I'll make an effort to help find that for you, and we'll make contact with you, Representative McDaniel, to get that to you.
All right. Any questions? Any closing thoughts and parting words? Our guests have the floor. What would you like us to know and do as a result of us spending this hour together?
Personally, I think you have seen where the nutrition programs are going, particularly at HBCUs. There have been some closings because of fewer students choosing the area. I think if we could get the word out about those programs. When I have students come to my program, a lot of them have no idea that we offer nutrition and dietetics programs at some of these HBCUs. It's not being talked about. It's not advertised often. And then if there were funding that's available for those folks, but my bigger issue is, because it's harder, is the MNT information. If we could get the legislators to push the Medical Nutrition Therapy Act to expand that to cover more individuals, particularly older people, to cover them in other areas. It's not just about diabetes and renal disease. It's too many other things that older people are sick with. So
I'm gonna feed off of that thought too, and say, the people who are on this webinar, and we're talking about MNT and the need to get the thing passed, don't accept, advocate. Okay? Don't accept what's there now if you know you can make it better. Okay? Use your experience, use your knowledge, use your passion, put it to work, and say MNT expansion is needed this Congress.
Yes.
So
thank you to our President Wandalyn Gavan, Nobel Women. I want you to, because we see you. I want you to raise your hand if you're committed, because I'm gonna take a picture. Here's my phone right here. Put it on blast. Raise your hand if you're committed to malnutrition care, and we're gonna go forward, and we're committing now to move this agenda forward. Thank you, everyone, for being here today. And we look forward to next year this time. We're going to come back and report out of the great work that we've done as a result of sharing this wonderful information. Let's make history together. Thank you all for being here today, and have a great Malnutrition Awareness Week.
Thank you very much.
Thank you.
Bye-bye.